My name is Gruenbaum. I'm the Chief Scientific Officer at Blood Cancer United, and I'm overseeing all our research activities. And of course, at ASH this year, we're particularly excited to continue to see really menin inhibitors emerging as a new type of targeted therapy for certain patients with acute myeloid leukemia. We've, of course, seen this data already emerge, and we at Blood Cancer United have actually been involved funding some of the very early work that helped understand the contribution of the menin KMT2A complex to actually promote acute myeloid leukemia again in certain patients. And we have significantly funded some of the early work at the University of Michigan by Yolanda Graham-Becker that ultimately led to what today is ziftomenib, which is, of course, the second approved menin inhibitor. We continue to be very actively involved at Blood Cancer United through clinical trials, both with revumenib, which is now part of our Beat AML master study, and the data has been published in JCO just earlier this year and also been presented earlier at conferences at ASH and EHA. We've seen really over the last couple of years with this increased understanding of the role of the complex and also the ability to understand how to target this interaction, because again, here we're looking at a protein-protein interaction, something that's classically much harder to target than inhibition of an enzyme, inhibition of a protein kinase, for example, where we've seen many success stories. So it's really exciting to see that, first of all, these approved agents that, of course, first were approved in the for patients who have been heavily pretreated in the relapsed refractory setting, are now moving towards earlier lines of therapy, including into frontline. And not unexpectedly, what we're seeing in these trials exploring frontline therapy are combinations, both with intensive chemotherapy, which is appropriate for patients in particular who are transplant eligible, as well as the combination of azacitidine and venetoclax that has been established for elderly unfit patients as a standard of care with the BLAA study, I think around 2020. So we're really seeing these regimens being explored, and it's exciting to already see much higher response rates. Durability data is evolving, but very encouraging signals. And based on the prominence in particular of NPM1 mutated AML, this can cover potentially 30% of patients. KMT2A-rearranged is a smaller percentage. This can be a significant step forward for many patients. In addition to these combinations with intensive chemo and with azacitidine venetoclax, there's of course also the potential for combination with other targeted therapies, such as, for example, FLT3 inhibitors, or with agents that also have immunomodulatory activity, such as the IMiDs, for example. And we also see some of these trials emerging. And then, of course, beyond that, we see many new agents, these learnings from the first approved agents, the clinical experience translating now into additional agents. And we're starting to see some differences between them. What I will say is the responses we've seen overall seem pretty consistent on the efficacy side. But of course, as we've seen for other agents, there are some differences in the side effect profile. And so for sure, this is not going to be one size fits all. Some of the themes that have emerged and that are being watched out for sure, and physicians will really have to pay attention to, are QTc prolongation, so potential risk of cardiac arrhythmias, differentiation syndrome. Some of these agents, revumenib, for example, has some drug-drug interactions as well. So those are just a few of the things that I think physicians will take into account. We're going to learn, A, how to handle them better. I think we're already seeing that with differentiation syndrome. And B, we're also going to see, again, there are different agents that are going to provide different benefits in terms of, the side effect profile, patients' pre-existing conditions, and then also potentially differences in the administration, twice daily or once daily. So a very exciting time, and I think we're going to see this field of menin inhibitors grow considerably and really understand more and more how to use it clinically.